This video is about the evaluation of hypotension. Sometimes the treatment's obvious. A bleeding trauma patient needs fluids, but it's not always so straightforward. Consider an obstetric patient who recently delivered outside the hospital and presents with hypotension. Rather than jump to a laundry list of possible diagnoses, I suggest a more disciplined approach based on physiology. But that requires that we understand the factors affecting blood pressure. First, it's dependent on cardiac output and afterload. One or both of those must be reduced for you to have hypotension. Cardiac output is the volume ejected by the heart per minute, so it's dependent on the heart rate as well as the stroke volume, the volume ejected per beat. One or both of those must be reduced to have a low cardiac output. Stroke volume is dependent on the volume of blood in the ventricle at the end of diastole, as well as what percentage of that blood is ejected. Ejection fraction is dependent in part on LV/EDV itself, based on Starling's law, but also on the contractility of the ventricle, the energy-dependent shortening of the muscle, and also the afterload. But here it's the reverse of the afterload. Increasing afterload reduces the ejection fraction. Back to end diastolic volume. It's dependent on the venous return, the amount of blood returned to the heart every minute, and also on the amount of volume that's left over in the ventricle at the end of systole, so the end systolic volume. Because it's a closed system, venous return has to equal cardiac output, so it's a little bit circular there. Meanwhile, venous return is dependent on the total intravascular volume, but also on where that volume is. So if you have very dilated veins, a high venous capacity, then you can keep the volume away from the heart. So there again, it's increasing venous capacity decreases venous return. And finally, on venous pressure gradients. So if you put someone in Trendelenburg position, you increase the venous pressure gradient and increase venous return. Regional wall motion abnormalities indicative of ischemia. Finally, afterload is a calculated value that you can only acquire by knowing the others. Once we've narrowed down which specific parameter is the problem, we can start thinking about actual diagnoses. For example, if we know it's an afterload problem, it could be sepsis, spinal shock after a spinal anesthetic, or medications. If it's the heart rate, it could be heart block, where we don't get atrial kick, or just a severely low heart rate. If it's a high afterload problem with a weakened heart, it could be a cross clamp on the aorta or certain medications. If we know it's a contractility problem, it could be ischemia, congestive heart failure, or medication or electrolyte problems. If the volume is low, it could be from hemorrhage or dehydration. A high venous capacity could be caused again by sepsis or by certain medications that are dramatic venodilators. And a venous pressure gradient problem could be caused by a head-up position, by retractors placed in the abdomen, or by large clots in the venous system. Even without a specific diagnosis, knowing which parameter is the problem allows us to institute therapy. So if it's an afterload problem, we need pressors. If it's a heart rate problem, we need to raise the heart rate, either pharmacologically or with a pacemaker. If it's extremely high afterload, we need to use a vasodilator. And if it's extremely low contractility, we need to use an inotrope. For volume problems, we obviously need to give volume and also possibly blood. If there's high venous capacity, again, we need to use pressors and the anti-shock trousers, which we use in trauma. And for a venous pressure gradient problem, we could place the patient into Trendelenburg's position. So I hope you can see that by thinking physiologically about hypotension, we can figure out what's going on and institute therapy, even if we don't have an exact diagnosis quite yet.